Good afternoon. My name is Division Chief Paul Johnson with Mountain View Fire Rescue. We're here today to discuss a new position, and it's within the North Central Region, or NCR, and it's called the Hospital Resource Officer. And its main task is to connect Incident Command with hospitals that are being affected by an incident. What is this position and why does it exist? It is a concept of operations that was delivered in response to the Marshall Fire, essentially. So originally we called this the Hospital Liaison Officer, and we intended to use it in a mass casualty incident setting. The idea was to send people to the hospitals to help out with MCIs. What ended up happening was we had the Marshall Fire, which, if you're unfamiliar with the Marshall Fire, happened in Colorado, and it basically burned down probably 1,100 homes. It was the largest fire in terms of property loss and damage in Colorado history. And during the course of the fire, we had to evacuate 2 hospitals, and that was during the COVID pandemic. And so it was obviously a large undertaking, and it went successfully. And we used the concepts from the Hospital Liaison Officer during that incident, and in the after action and follow-up, we decided that that position worked really well and that we needed to formalize it a little bit into more of a true incident command position. So that is the why behind why we did what we did and what this position is meant to facilitate. And so we'll talk about what it developed into and where it's at today. Something to note for this is that it was a long multi-year process that we developed this over. We included many stakeholders, including the North Central Region Healthcare Coalition, the Foothills and Mile High RETACs, hospitals, EMS agencies, fire departments, law enforcement agencies, dispatch centers. It had a really good stakeholder group, and we felt that was important to build the momentum needed to really kind of bring this position to fruition. Everybody was included in the process, and also we designed the position to fit within the framework of the Incident Command System or the National Incident Management System. It was designed to align with the national preparedness goals. So if you're thinking of using this for any position in your own ICS or anything like that, just know that it was designed to be used. And we named it specifically the Hospital Resource Officer because if the ICS purists out there were around, they would tell you that a liaison cannot command and or control any resources. So we came up with the term Hospital Resource Officer as a way to truly facilitate and provide this position with the ability to do everything that it needed to do. What is the overall mission and scope of the Hospital Resource Officer? So the number one mission is to provide the critical link between the on-scene incident command and the impacted hospitals. And the scope of that is to provide expertise on EMS operations and serve as a subject matter expert to assist the hospital to make operational decisions. So essentially our main goal is to provide that link between the hospital and the incident command so that they know what's going on and we know what's going on. Think of it as if you have an MCI and you call the hospital or you use EM resource and you say, hey, we need a patient bed count. We got this big MCI, and you never call back. And meanwhile, the hospital has, cleared CT scanners. They've called in surgeons and nurses and other folks that can help out at the hospital. They're prepped and ready, and for hours they sit there and we never call back. And I've been on a couple incidents where this has happened. We've been notoriously doing this to hospitals for years, and they're just left kind of wondering, like, are we ever going to get any patients? What's going on? And on the flip side of that is if we transport a bunch of patients to a hospital during an MCI, it does us no good to get all the patients off the scene and then we high-five each other, tell ourselves we did a great job. Meanwhile, there's 100 patients in the parking lot of the hospital that have not gotten to see a doctor yet. So before we release those resources of ambulances and stuff, we should go to the hospitals and decompress the hospitals. Move those patients farther out so that they can get to definitive care. So it really does provide that link up between the hospital and the incident command, and we'll kind of talk about how that occurs, but that is the main gist of what we were looking to provide. Talking about the mission and scope, I think that lays it out nicely. So there are 3 primary functions for a hospital resource officer. Number 1 is to information gather for situational awareness. Number 2 is to resource coordination, right? So we want them to coordinate resources, they can call and request for ambulances. And then function 3 really is patient movement. So a true hospital resource officer can facilitate all 3 of those things. And again, it's that situational awareness, resource coordination, and patient movement if needed. And that can be either to the hospital or away from the hospital. A key piece of this lecture is to talk about who we think should be an HRO, who should fill this position, because it is important. The preferred knowledge and skills of somebody who could fill this position would be knowledge of the EMS system in general, the bigger, broader EMS system, knowledge of EMS resources and how to obtain those resources. So do you know how to order resources? Can you find them? Do you know how to use EM resource? Do you know how to order through an alternate dispatch center? Do you know all those kinds of things? It should be somebody that has that knowledge. It should be somebody that has the ability to function within the ICS, so within the incident command system. Oftentimes a command level, an officer level, captain, supervisor, something along those lines. We recommend an EMS leader, ideally an EMS chief, captain, lieutenant, SAM officer, whatever name you choose to describe that person. That's the ideal person to fill this role. Knowledge of hospital operations and the resources that are needed for that hospital and the resources that can come to the hospital. So again, sort of hospital knowledge, EMS system knowledge, where that crossover occurs is the ideal person. And finally, knowledge of the regional healthcare response, and specifically if you're within the North Central Region Healthcare Coalition, there's a regional hospital coordination plan and MCI plans and many other plans that deal with all this stuff, but we want you to be familiar with that if you plan on filling this role. Oftentimes when I give this lecture, I get questions about ordering resources. There's several ways to do that. We typically tell people you should have multiple plans and options for this. Some of the ways we recommend are, if you're operating within ICS, your first choice is always to order through your supervisor, right? So you go up the chain of command. If, and what we experienced at the Marshall Fire was there were no resources available, and then, that happened at the state level. But we had state officers reach out, we had RETAC officers reach out, and we had healthcare coalition people reach out. And so what I describe to people in this event is, no multiple ways to order resources. So for us, that's order through your supervisor first. If you can't get resources that way, order through your dispatch center. If you can't get resources that way, go to an alternate dispatch center that's not involved in the incident and try to order through them. Order through EM resources. If you're within the North Central Region, the North Central Region Healthcare Coalition has a 24-hour duty officer line. You could call that number and request help. And that's what we did during the Marshall Fire. We ended up getting a hold of the Healthcare Coalition, and they were able to provide us assistance with ordering through EM resources. They coordinated with Boulder County Office of Emergency Management, and they were able to find us quite a few resources that didn't come up through other means. So I guess my takeaway from that is know lots of ways to order resources and know how and when to use them. Which is why, again, we would recommend somebody in sort of a chief officer, SAM officer, captain, lieutenant supervisor sort of role for somebody to fill this position. Where does the HRO fit into ICS? Well, they are the true connection between the incident command and the hospital. The difference is they are located at the hospital. That is their ideal position. And we'll talk about how they get ordered and how they get there, but just know that they are that true link in the middle that connects those two different entities. And hospitals will use what they call HICS, or Hospital Incident Command System. And then the normal incident on scene is using their incident command system. So you really are the true connection between two different ICS structures. Let's talk about how an HRO can be activated. So how does this work? Typically, HRO activations occur for, the way we envisioned it. So an incident which activates an MCI plan. So if you're utilizing your MCI plan, you're asking for bed counts and you're potentially impacting a hospital, that is a really good time to consider that you should send an HRO to the affected hospitals. One of the things we do discuss is, if you're not sure, you don't have, all the hospitals that are going to be impacted, you might assign one HRO to handle multiple hospitals, and they can just phone in and be a point of contact. Hey, we don't think you're going to be impacted by this. We still want to get your bed count, but just here's a phone number to call if you feel like you need to. We'll keep you apprised of the situation, but just so somebody's a little more focused on the hospitals and what's going on. Another HRO activation criteria could be an incident which activates a hospital evacuation. So again, the Marshall Fire example where smoke and fire impacted the hospitals and we ended up having to evacuate 2 hospitals more or less during that incident. Something along those lines would be a great time to activate an HRO. The next one would be a local hospital requires information from an event to make internal operational decisions. So kind of like we discussed, let's say there's a, an active shooter or some large-scale incident that is occurring. The hospital's not sure if they're going to be impacted or not. They can call up and request an HRO be assigned to them. And then finally, the last activation criteria is a hospital requests an HRO. So they are being impacted, something is going on, and they can call and request an HRO. So a good example of this might be, we know that a large number of patients get, self-transport from a mass casualty incident. All the people that can leave the scene, leave the scene. We saw this in lots of places, but Las Vegas comes to mind off the top of my head, where a bunch of patients left and went to the local hospitals, and the hospital is suddenly inundated with lots of patients. Keep in mind that when we ask for EM resource bed counts, that's a snapshot in time. So a lot of times what happens is we ask for bed counts. Hospital might say we can take 2 reds, 10 yellows, and 20 greens. And then all these patients suddenly show up at the hospital, and then we're still thinking we can transport, 32 patients there, but they're already full. So the hospital might call in and say, hey, we're being impacted by this event. Can you please assign us a hospital resource officer to come help out with that? So that's hopefully a good example of how that might play out. Who can request an HRO? There's basically 2 lines. It can either be incident command initiated or hospital initiated. Incident command initiated, we envision this to be like an actual mass casualty incident. So something that is going on where we have a large number of patients, we're requesting bed counts, and we're sending patients out to various hospitals and impacting them. Incident command should use this as a moment to say we should send each of the affected hospitals a hospital resource officer. So that would be an example of incident command initiating an HRO. Where we envision them working is under the medical branch. So similar along the lines where you'd have a triage, treatment, and transport officer, now you just have a hospital resource officer as well, reporting to the medical branch. So if you're thinking of ICS, that's where they would fit into the structure. Lastly, we can have hospital initiated. So talked about this briefly, but some incident that is impacting the hospitals, and the hospitals can call dispatch and ask for a hospital resource officer to be assigned. So key point for this is for your incident commanders to know that they might get a request through dispatch that says, hey, we need a hospital resource officer. They should know what that is, and they should know who to assign that to. So they would assign it to medical branch. Medical branch would appoint a hospital resource officer to wherever it's needed. With this point, hospitals know to call the non-emergent line, but it's not the public non-emergent line. When we developed this whole concept, the dispatchers didn't want the hospitals calling 911 because they're inundated anyway, and they didn't want them calling the public line because the public line is usually swamped. So most dispatch centers agreed. They have a number that goes right to the dispatcher. The hospitals are supposed to have that information, know how to access the dispatch center within their area, and they will call dispatch and request, and that request will be sent to the incident commander, and then that will be just another request for position or information that needs to be filled. With that, that is the general concept. It's a fairly easy concept. Like most things, it can get complex when you're trying to evacuate a hospital and you're needing a lot of resources and all that stuff, but the concept of how it fits in and where it fits in and how that should be facilitated is pretty easy. To help you with the more complex stuff, the North Central region developed some helpful tools, namely checklists. So there are, on the Healthcare Coalition website, there's a whole toolkit that goes along with this. And part of that is HRO checklists. And so if you are assigned as an HRO, there is a checklist in there for you. And you can pull out the checklist and run down the checklist of like, oh, I'm supposed to tie in with hospital incident command when I get there. The level we envision that at is at the operations level. So if you're assigned as an HRO, you would go to the hospital, go down your checklist. First thing on there is check in with incident command. Go inside the hospital, find their incident command, and get tied in at the operations level. Let the ops officer know who you are, let them know what you're there to do, and most likely they will send you back out to the emergency room where you'll tie in with a charge nurse or somebody that's out there, and that'll be your position for the duration of the incident, because that's where you'll have the most impact. But we do need to check in with incident command when we get there. There are checklists for hospitals. Now again, these are just some small examples that you're seeing on the slides, but there's hospital checklists, HRO checklists, there's EMS and fire checklists. They're all on the checklist for you should you need it, and hopefully that will make your experience easy. There is a dispatch checklist, so they probably don't hear about this very often, but they do have a checklist of their own, and they should be able to pull this out and reference it if they need it. There's also checklists for North Central Region Healthcare Coalition, Local Emergency Management EOC, Local Public Health, ESF8 folks. So all the checklists are there for you. You can have those in your plan. The other thing we created was an exercise in a box toolkit. So this lecture here was meant to be sort of a little bit of a train the trainer, but also just a concept of operations. Here's what's developed, and now you can take this back to your department and hopefully develop it out a little bit further. So we created an exercise in a box toolkit for you. It lines up with all of the FEMA standards for how an exercise should be developed and stuff. So if you need to practice, if you want to put on your own test case, tabletop, full scale, whatever, there is a exercise in a box toolkit, which is great. The other things that are in the toolkit for you are exercise plan template, an exercise facilitator guide, participant feedback form, exercise evaluation guide template, and an after action report and improvement plan. All that is available for you on the Healthcare Coalition website and easily accessed. If you need any follow-up information, please feel free to reach out to the information that's on the screen. And again, if you would like any of the material that was referenced in the lecture, the trainings, the toolkits, any of that stuff is available through the North Central Region Healthcare Coalition, and it's on their website, which is also listed on your screen. Thanks again for being here. Have a great day.